Testing 1 2. Test test. Test 1 2. Testing 1 2. Test test. Testing 1 2.
Ready to go?
Yeah, whenever you get ready.
Okay. So I guess we're going to go ahead and get started. My name's Ryan Buckner. I'm a radiologist here with Birmingham Radiology Group. And actually, it's a real honor to speak here at this hospital. I grew up just down the road at Springville, was actually a patient here at this hospital a while back. So nice to be a part of the community again, and happy to speak here. Thank you for joining us. So a brief, just while we're talking about this, I started sort of learning about the TI-RADS system, which we'll talk about, because when I started here, we were doing thyroid FNAs, which I had not really done before, and realized that there was a gap in my knowledge about thyroid FNA and sort of the details of when to do it, when not. This TI-RADS information is relatively new. It came out about a year ago. And at a cancer conference, Carol Kinnemer, a fellow Springville citizen, asked me if I would speak here. So that's how I kind of got roped into this presentation. And it's been really useful to me to learn more about it. Hopefully you'll get some information out of it as well. So I'm going to talk briefly about thyroid disease, focusing on thyroid nodules and thyroid malignancy. I want to discuss imaging of the thyroid, how we do it, what its limitations are, and then we'll spend most of the information discussing the TI-RADS classification of thyroid nodules. No financial disclosures, unfortunately. So when you're talking about thyroid disease, basically it's broken down into these groups. We have diffuse enlargement, goiter, endocrine disease, with a variety of different causes, including the autoimmune diseases that we're all relatively familiar with, Graves' disease and Hashimoto's. And then there's nodular disease, which is basically broken down into benign disease, including the most common cause of thyroid nodules, adenomas, colloid nodules, and multinodular goiter. And then there's thyroid cancer or malignancy. So thyroid disease is very common. For every 100,000 patients that are evaluated, 350 will be diagnosed with hypothyroidism and 80 will be diagnosed with hyperthyroidism. And along that same line, thyroid nodules are also extremely common, with autopsy studies showing nodules in 65% of individuals. And each nodule, just kind of anecdotally, will carry a 7 to 9% risk of malignancy. So there's a lot of nodules, and some fair minority of those will have malignancy associated with them. So this is the most recent National Cancer Institute data on thyroid cancer. An estimated 53,000, almost 54,000 cases will be diagnosed in 2018. This accounts for about 3.1% of all new cases of cancer in the U.S. It roughly causes about 2,000 deaths a year, which represents about 0.3% of all cancer deaths. And this 5-year survival is very good, 98.1%. So this is just for comparison purposes, really. Top left is just a chart showing the thyroid cancer sort of most recent statistics, with the bottom right being breast cancer for comparison. As you can see, a lot more cases of breast cancer. It's a higher percentage of breast cancer for the total number of cancers diagnosed. And it also accounts for a higher number of deaths. The 5-year survival is obviously not as well. And then we'll come back to this top left chart in a minute, but just notice the increasing number or the incidence on that bottom part of the chart, but we'll come back to that in a few minutes. So basically, thyroid cancer is broken down into well-differentiated tumors, including papillary carcinoma, which is the most common form that we find. Follicular carcinomas or follicular variants are also well-differentiated. And then the more poorly differentiated tumors include medullary carcinoma, anaplastic carcinoma. There are other rare forms of malignancy in the thyroid, including lymphoma, sarcoma and teratomas, and then very, very rarely we see metastatic disease. I can't actually say that I've seen that personally, but it can happen. So treatment options, these are staged according to T&M guidelines, and then depending on the stage at diagnosis, options range from surgery, radiation therapy. For some of the lower grade tumors, there's some evidence that just active surveillance is adequate. So who gets thyroid cancer? Well, there are some genetic disorders that predispose patients to malignancy of the thyroid. Those are called multiple endocrine neoplasia, specifically type 2A and B. It's a RET gene mutation. Patients with a history of goiter, female predominance, patients with from Asian descent, and any patient that's had a history of head and neck radiation is at increased risk as well. So as we saw previously, the incidence of thyroid diagnosis has increased dramatically in the last 30 years. In 1992, it looked like it was about 6 per 100,000. Now it's well over, 14 per 100,000 people. So why is that? What's going on? And this proves to be true across patients of different from white, African American. Every section of the patient population has experienced increased incidence in diagnosis. And we'll also talk more about this in a few minutes, but you might notice on the right that mortality has remained relatively low and relatively constant. Well, so why have we diagnosed more? Well, let me walk you through a brief history of medical imaging. So in 1963, the development of handheld articulated contact B-mode scanner was developed. B-mode is just the most common type of ultrasound scanner that we use. In 1967, the first commercially viable CT scanner was put into production. And in the 70s, we started to use more medical MRI. Then in 2001, PET-CT became available. And all of these modalities have experienced significant increase in utilization since they've become available. So we image the thyroid on a lot of different studies. Any imaging of the neck, including cervical spine CTs, CTs of the chest, CTA of the neck, carotid Doppler. We'll often incidentally image the thyroid, and MRIs of the neck and cervical spine. PET-CT is also, we obviously image both the thyroid and can evaluate the metabolic uptake within the thyroid. So we're finding more of these nodules because we're imaging the thyroid so often, and basically it's leading to more patients being introduced to thyroid nodule workup and subsequent biopsy. In fact, the ACR released this statement in their white paper on incidental thyroid findings that incidental thyroid nodules are the most common incidental findings with increased rates of reporting. There's also a great degree of variability in reporting and low threshold for biopsy. This results in significant patient anxiety, increased morbidity, and is a cumulatively very costly problem for our healthcare system. So why we've been diagnosing more thyroid cancers without any significant change in mortality. Well, what does that mean? Well, it sort of suggests that there's gaps in our understanding of how thyroid cancer actually works and its effects on patients. Very recently in South Korea, they offered low-cost thyroid cancer screening that started after 1999. And what resulted was essentially a significant increase in the cancer diagnosis, with over 40,000 cases diagnosed in 2011. But they found there was no significant change in the mortality over the course of the screening program, with roughly 300 to 400 patients dying per year of thyroid cancer. And that was before and after implementing the screening program. So, and of course, with these thyroid cancers and with our interventions, there is non-trivial morbidity, including vocal cord paralysis and hypothyroidism that results. So, again, it suggests that there's some sort of gap in our understanding. While these nodules that we're evaluating are malignant, a lot of them, if left alone, would not progress to lethal cancers. And because of this, the U.S. Preventative Task Force recommends against thyroid screening, currently Class D recommendations. So we shouldn't be screening patients. Who should we be imaging? Well, any patient that it has unexplained dysphagia, hoarseness, or any sort of clinically evident mass, if you can see a growth coming from someone's neck, certainly image those patients. There's really not any widely accepted recommendations for the high-risk patients that I mentioned earlier. That should be, it's kind of up to the clinician on how best to manage those patients. I don't really have any great guidance for those particular patients. And as I said, there are nodules that we notice incidentally during the workup of non-thyroid related problems. And if those meet the proper guidelines, which we'll discuss in a few minutes, those should be imaged as well. Any nodule that is palpable on exam is probably either very superficial or large and should be worked up with thyroid ultrasound as well. So this is how the white paper that came out in 2015 from the ACR recommends the management of incidental nodules detected on CT or MRI. As you can see, anything with suspicious findings, which would probably include adenopathy, needs to go straight to ultrasound. And otherwise, it gets broken down into basically your age populations. Less than 35 years, an incidental nodule greater than or equal to a centimeter should be evaluated. Over 35, it needs to be greater than or equal to 1.5 centimeters to warrant further evaluation. On PET CT, anything with focal activity probably needs to be evaluated further. If it doesn't have focal activity, then it kind of gets lumped back into the CT category, which was on the previous slide. And then any sort of nodule detected at ultrasound, for example, a carotid or soft tissue ultrasound, these are the breakdown of the kind of the way that those should be evaluated. And you really do need a dedicated thyroid ultrasound to evaluate the entire gland in these instances. Even if you notice a nodule on one particular side during say for an example, a carotid ultrasound, you need to evaluate the entire gland to evaluate for other suspicious nodules that you may not see on the contralateral side, for example. So how do we image the thyroid? Well, ultrasound is kind of the mainstay. It's relatively inexpensive. There's no ionizing radiation. It's non-invasive. Because of the location of the thyroid gland, we can use high-frequency ultrasound, which gives us accurate size measurement and solid and cystic characterization, and it allows us to detect both macrocalcifications and microcalcifications. We can use Doppler flow to try to distinguish between solid and cystic nodules, and if there are abnormal lymph nodes in the area, we can see those with ultrasound as well. The limitations, any nodule or portion of a thyroid that extends below the sternum is difficult to evaluate with ultrasound. And there is some operator dependency involved with ultrasound. But it remains the modality of choice for the initial workup of suspected thyroid abnormalities. So this is it's kind of an older ultrasound image, but it kind of gives you a good layout of the anatomy that we see. Imagine the patient's feet are coming out at you, so this is the right, this is the left, the trachea. These are the strap muscles, which we'll mention later because they're important to note. Again, the top left is just another image of a normal thyroid. This is an ultrasound image of a complex cystic nodule. On the bottom, we have a more solid nodule, and in this case, there's internal Doppler flow, which lets us know that the nodule is solid. So we see a lot of these on CT and MRI, but there's really no role for CT or MRI in the nodule workup. There's exposure to ionizing radiation. While we can accurately measure the size, it's relatively inaccurate for characterization of the internal contents. We can definitely see abnormal lymph nodes in the neck. And then just an aside, administration of contrast does preclude further workup or imaging with scintigraphy. And if the patient was to need iodine therapies such as iodine-131, recent administration of IV contrast can preclude that as well. So this is an image of a PET CT. We use F18 FDG, so F18 is our our PET agent, our positron emitter, and FDG is a glucose analog. And for example, in this case, you can see marked uptake in the left lobe of the thyroid. So unfortunately, there's no real role for this in a nodule workup. As I mentioned previously, if a nodule does demonstrate focal activity, it probably needs to be evaluated with ultrasound. And PET is also sort of limited use in thyroid malignancy staging just because of the variable degree of FDG uptake within the malignancy and lymph nodes. So thyroid scintigraphy, the agents that we have available, technetium-99, pertechnetate, iodine-123, and iodine-131. So this is useful to sort of characterize nodules that maybe we've seen on ultrasound or other imaging studies. We can classify a nodule as hot, cold, or warm, with cold nodules demonstrating a roughly 10% risk of malignancy, and hot nodules demonstrating a relative risk of malignancy of less than 1%. So that information can be useful in some instances. And then we can calculate the thyroid uptake, which is essentially a measurement of the metabolic activity of the thyroid, which is useful in sort of distinguishing between different disease states of the thyroid. It's difficult to accurately estimate the size of a nodule on scintigraphy, and without any sort of anatomic correlative imaging such as an ultrasound or a CT to know where the gland is and where a nodule might be, it can be difficult to interpret, and there is some ionizing radiation exposure. So the last part about thyroid imaging is just the thyroid FNA, which we do under ultrasound. Relatively straightforward procedure. The neck is prepped and draped. We use chlorhexidine to clean the skin off, lidocaine for local anesthesia, advance small 22-gauge needles into the nodule directly under ultrasound guidance. We like to see the nodule directly, or the needle directly within the nodule. You aspirate within the nodule as you move the needle back and forth, and the sample is provided to a cytopathology technologist who confirms the adequacy of the sample there at the time of the exam or the procedure. Even with the adequate sample, there is a risk of the specimen being non-diagnostic when it's actually evaluated by a pathologist. Adequate samples are classified by the pathologist according to the Bethesda classification system. And basically, these are kind of broken down into different categories. The pathologist will sort of decide which category does it get lumped into, and then each of those categories has their own risk of malignancy associated with them, which are in the brackets out to the side there. So thyroid FNA report, these are kind of standard reports, reports of statistics, good sensitivity, good specificity, relatively low false negative and false positive rate, and is a relatively accurate way to evaluate the pathology of these thyroid nodules. Anytime we put a needle in the skin, there's risk of bleeding, risk of infection. I always tell patients there's a risk that the sample may come back non-diagnostic, which may require additional FNA or biopsy. And then there is a small risk that we could injure adjacent structures. Again, we like to visualize the needle tip during the entirety of the procedure, but there are vessels, the trachea is in that region as well. Again, this is operator dependent as well. Some people just have more experience doing these than others. So who needs FNA? So for people that are treating patients with thyroid disease and thyroid nodules, it's important to recognize that thyroid nodules are common, that we commonly identify them on imaging, and that thyroid malignancy is present in a minority of these nodules. But there are some gaps in our understanding of the thyroid malignancy. And our goal should be to identify and treat what is or what might become clinically significant disease and avoid unnecessary treatment and intervention. So this brings me to the last part of the final section of the of the presentation. And I want to spend this talking about TI-RADS, which was essentially developed in response to the increasing rate of thyroid nodules and thyroid malignancy and the increasing request for biopsy and FNA. So in 2012, the ACR convened committees of experts consisting of radiologists with extensive expertise in thyroid imaging. And they had 3 goals when they convened. The first was to provide recommendations for reporting incidental thyroid nodules. And that's kind of what we touched on earlier with the decision-making tree for nodules that are identified on non-thyroid ultrasound. The second goal was to develop a set of standard terms or a lexicon for ultrasound reporting, which we call the TI-RADS system. And the third and final goal was to develop a system to assist clinicians with decision-making regarding FNA and follow-up studies of the nodules that we've identified. So in 2015, the first 2 goals were addressed. The Journal of the American College of Radiology published 2 articles, Managing Incidental Thyroid Nodules Detected on Imaging, which again was the incidental thyroid nodule breakdown with that we covered earlier. And the second was the Thyroid Ultrasound Reporting Lexicon, which basically gave us a standard lexicon or a standard way of reporting and describing thyroid nodules. So originally the committee evaluated 9 possible imaging features. Eventually they settled, they went back through the literature to try to determine which of those 9 possible imaging features had the highest correlation with thyroid malignancy, and eventually settled on 6 different imaging characterization, or 6 ways to characterize nodules, and implemented those into the TI-RADS classification scheme. So these are the 6 categories that they came up with. Composition, which is broken down into solid and cystic; echogenicity, hyperechoic, isoechoic, hypo, or very hypoechoic. Shape is pretty simple, taller than wide. Size, we want to measure the maximum diameter. Margins, smooth versus irregular, and echogenic foci. So when we're talking about the composition of a nodule, it's broken down into these different components, or it can be broken down into these different components. A solid nodule should almost be entirely solid, so 95% of the nodule needs to be solid in order to be characterized as a solid nodule. If it's less than 95%, it's either it's considered mixed solid and cystic, and either predominantly solid or predominantly cystic, given the more predominant characteristic. A cystic nodule needs to be entirely cystic, no solid components, no septations. And then, as I described earlier, we can use Doppler flow in some of the more complex cases to distinguish between a solid nodule or a nodule that just has complex kind of debris within it. So the purely cystic and spongiform nodules, which I have an example of, carry a low risk of malignancy. So top left, just a good example of a nice solid nodule. This is what we would consider a spongiform nodule. It consists of small cystic spaces, not to be confused with a solid and cystic nodule where you have these rinds of soft tissue or thick echogenic septations. So the second category is echogenicity, and we compare the nodule to the adjacent thyroid tissue to determine where it falls on the echogenicity spectrum. So you can have hyperechoic, essentially it's brighter than the adjacent thyroid; isoechoic, which can be hard to distinguish but from the adjacent thyroid; and hypoechoic, which is darker or less echoic than adjacent thyroid. And as I mentioned earlier, we want to see the strap muscles, because nodules that are very hypoechoic are darker or less echoic than the adjacent, than the strap muscles. And that's the most suspicious echogenic feature that a nodule can have. Again, we use the predominant echogenicity. Some of these are mixed echogenicity with some parts darker and brighter. We use the predominant echogenicity within the nodule. And if a nodule is solid and cystic, we want to use the solid portion to determine the echogenicity. So a good example of a hyperechoic nodule, it's at least isoechoic, maybe slightly hyperechoic to the adjacent thyroid here. The middle picture shows a good example of a sort of isoechoic where it's hard to distinguish where the nodule starts and stops. And then the very bottom picture, this is the nodule, the strap muscle, this is the carotid. So this nodule is darker than the strap muscle, very, very hypoechoic, which is the most suspicious of the echogenic features. So shape is pretty simple. What we do is we put the transducer on the neck, sort of like this. It's called the transverse plane. And we measure the nodule. And if it's taller in anterior to posterior or AP dimension than it is wide in the transverse dimension, that's wider than tall, and that's considered more suspicious. And then we measure the maximum diameter, and we want three-dimensional measurements to do this. So the margins are basically the way the nodule interacts with the adjacent thyroid gland. You can have smooth nodules, irregular, which are spiculated, jagged, or angulated. Lobulated means it's just kind of more rounded contours, ill-defined, where it's difficult to determine where the nodule starts and stops. Some nodules will demonstrate a very hypoechoic or dark rim around the border. And then we want to see if there's extrathyroid extension beyond the margins of the gland, or if it's infiltrating into the adjacent soft tissues, which is obviously a worse or a more suspicious more suspicious feature. So on the left is a smooth nodule. Again, you can draw a line all the way around that nodule. The borders are smooth throughout. The one on the right has some lobulated and more angulated contours there, so that one will be classified as irregular. So echogenic foci are areas of increased echogenicity within a nodule. And these are often reflective of microcalcifications. The thicker calcifications, the chunkier calcifications that shadow are compatible with macrocalcifications. Some of the nodules are peripherally calcified, which is not necessarily suspicious in and of itself, but it can obscure the contents of the nodule and make it difficult to accurately characterize it. And then there are special calcifications or echogenic foci called comet tail artifact, which are associated with colloid and therefore suggestive of malignity. So this is that colloid comet tail artifact, where it's got this little tail coming off the back end of it. Again, that's associated with benign nodules. The top right, these are the coarse, thick calcifications with posterior shadowing. This nodule is calcified around the periphery. Again, it can obscure the contents. And then, if you look really closely, all within this nodule are tiny little echogenic foci, which can be seen with microcalcifications. All right, so we've talked about who needs thyroid ultrasound, and we've talked about how to classify the nodules that we see with ultrasound, but what do you do as the clinician or the provider with this information? Well, in 2017, the ACR released a new paper which basically outlined a management system based on the TI-RADS lexicon. And this is it. So I'll take a second just to kind of walk through how we use this, but this is sort of the main part of that last paper that came out. So basically we have on the top all the different characteristics that we covered, the 5 different categories. The least suspicious of those categories are assigned usually 0 points. As you go down to more suspicious features, they're assigned higher points. So you go from each category and give the nodule a score based on its components. And those get added together to give you a total point score here. Based on the total point score, the nodule is assigned to a TI-RADS 1 all the way to a TI-RADS 5. And then if you'll notice, there were 6 characterizations. Those were the 5 up here. The last component is the size. So TI-RADS 1 and 2 are considered not suspicious. But once you get to a TI-RADS 3, 4, or 5, based on the size of the nodule, you either don't do anything, don't follow it up, you follow it up, or FNA. So it's a very useful system to evaluate nodules and to help kind of guide the management. One point that I learned that was probably important to know about this sort of scoring system, the calcifications, a nodule can have more than one type of calcification. Those are cumulative in that particular category. So what are the attributes? What are the good things about this system? Well, it was founded on the previously published TI-RADS lexicon, which is again a standardized way of describing and classifying nodules. It's easy to apply. There's nothing special that you have to do. I mean, it's still a thyroid ultrasound, so it can be applied across all ultrasound practices. It has the ability to classify every thyroid nodule, and it's an evidence-based system to the greatest extent possible. So the overarching goal with this system is to provide a reliable and non-invasive way to identify which nodules need FNA based on the reasonable likelihood of developing into biologically significant malignancy. What does it not address? Well, if you've previously had a thyroid FNA, it doesn't really give you a lot of guidance as to what to do with that particular nodule. That should probably be driven by the patient and the referring physician, as well as the cytopathology from the previous FNA. What do you do if a nodule grows? Well, they define a significant growth as 20% increase in at least 2 different nodule dimensions, but it doesn't really say what to do with the nodule if it does grow during the course of evaluating it. What should the follow-up timing be? So as we said, TI-RADS 3, 4, and 5 lesions, if they meet a certain size, need to be followed up. Well, what is the interval? So the ACR does not recommend repeating a thyroid ultrasound within a year. So all of these nodules will be evaluated at yearly intervals. For TI-RADS 5 lesions, you need to evaluate the lesion every year for about 5 years. For TI-RADS 4 lesions, the nodules need to be evaluated with ultrasound at year 1, 2, 3, and 5, and that's out from the initial exam. And then for TI-RADS 3 lesions, you should repeat the ultrasound at 1 year, 3 year, and 5 years. So they do sort of recommend that if it increases significantly in size but remains below biopsy threshold levels, you might want to consider continued surveillance beyond 5 years. And any nodule that increases by 1 TI-RADS level, so if it goes from a 3 to a 4 or a 4 to a 5, you should probably evaluate that nodule again in 1 year. As far as our reports, the recommendations that they give is that we report no more than 4 nodules, and obviously those should be the most suspicious nodules that we identify during an exam. If a thyroid FNA is recommended, we should only recommend FNA of the 2 most suspicious nodules identified. And if you've read reports before, and I've used this wording, dominant nodule, should probably be avoided in the reporting because it simply really only takes into account the size of the nodule and not the other important imaging features that we discussed earlier. We should be assessing cervical lymph nodes at the time of our ultrasounds, and those should be commented upon. What we look for is normally a lymph node has a sort of what we call reniform or a kidney bean shaped with a normal kind of fatty hilum. So if you lose that fatty hilum, if you see peripheral Doppler flow rather than a central vascular pedicle within a lymph node, or if the nodule is larger or the lymph node is larger than 1 centimeter in short axis diameter, those can be suspicious features. And just like the thyroid nodules themselves, some of these nodules, if they contain metastatic disease, can have microcalcifications. So that should be important to recognize during ultrasound as well. And just like the thyroid nodules themselves, if you identify a suspicious lymph node, that can be aspirated at the time of thyroid FNA as well. So this is in the research that I did, including watching some frequently asked questions about this system. This is one point that's kind of difficult to wrap your head around, I guess, but nodules that meet TI-RADS 3, 4, and 5 criteria but are below follow-up threshold. So the thought is that the first 5 criteria will give you an inherent risk of malignancy within a nodule, and the size is supposed to be used as to help you determine whether or not a nodule will be clinically significant. So if it's below size threshold, it may still harbor malignancy, but it's thought that that will not develop into a clinically significant thyroid nodule. But that's, can be hard to kind of wrap your head around, because some of these nodules may be, discovered early on. I mean, a clinically significant nodule has to start somewhere. That's potentially one weakness of this scoring system. Another point is that this system is not designed for use in pediatric population. However, if you have a suspicious or somewhat suspicious thyroid nodule in a pediatric population, it should be looked at more. It should be looked at with greater suspicion than even in the adult population, because the nodules themselves are less common in the pediatric population. So where does the TI-RADS system go from here? Well, it doesn't, there are some ultrasound characteristics that it doesn't take into account. Those include sonographic elastography, which we use now to evaluate, for instance, for liver disease. There is a goal to harmonize the TI-RADS system with other imaging modalities. For example, the thyroid scintigraphy. If you have a cold nodule which has a reported higher risk of malignancy, how does that get factored into TI-RADS scoring? Hopefully that will be addressed in future research and future papers that come out. And then there are a lot of different scoring systems out there, and I'll touch on those in a second as well. The goal is to develop an internationally accepted TI-RADS, which takes a lot of the similarities of these different systems and kind of combines them into one widely accepted, effective classification scheme. This is just to show you that there are other systems out there. This is from the American Thyroid Association. Basically, they've broken down these nodules into high suspicion, intermediate suspicion, low suspicion, very low and benign nodules. You take a nodule that you see at ultrasound and try to match it up with what looks the most similar on this chart, and it gets lumped into the appropriate category. And then based on that, they do give some recommendations regarding when to FNA or when not to FNA. Again, one of the strengths of the TI-RADS system that is a potential weakness within this one, some nodules are not classifiable. They don't fit nicely into one of these categories. In fact, one paper demonstrated that 14% of nodules were unable to be classified by the American Thyroid Association scheme. And within those 14%, 9% were found to be malignant. So that's one weakness of that particular system. This is another classification system from the Society of Radiologists and Ultrasound. Again, it gives ultrasound features which are thought to be suspicious, and then at what size to strongly consider FNA. One thing to point out, and again, I guess radiologists like to use kind of hedgy words, wording. Strongly consider ultrasound. The TI-RADS is definitely more definitive, and this particular system doesn't really give a lot of guidance about what to do for follow-up. So this is just a chart kind of outlining some of the differences. These are the major points about characterization between each of the systems. With the TI-RADS, again, the nice thing about it is for me, it's easy. It's standardized lexicon, which is basically predetermined words that you're going to put in your report to describe these nodules. You assess the risk on the 5 categories, which is not really a component of the other classification schemes. Also differences in management, like I pointed out before, There are clear size thresholds for follow-up and clear size thresholds for FNA based on each of the TI-RADS scores, whereas the other ones are slightly more vague in their recommendations, and there are no specific follow-up guidelines. So how does it do compared to these, in actual practice? Well, this is a small scale study, but 100 cases were evaluated retrospectively and these were 100 cases with known pathology. As you can see, the ACR TI-RADS recommended biopsy in notably less cases than the other classification systems, and that was I think that was kind of the goal when the panel was putting this together. We want to decrease the number of unnecessary biopsies. So that kind of demonstrates that the system works the way it's supposed to. The sensitivity in this particular instance was very similar across all the different classification schemes. That has not really held up in larger scale studies. The sensitivity is decreased in the ACR TI-RADS. Again, that's part of the way it was designed. You're kind of accepting that you're going to miss malignancies potentially, but the way that the system is designed, that you're not supposed to miss clinically significant malignancies. These are malignancies that would cause potential morbidity and mortality to the patient. The specificity and the accuracy in this case and in additional larger scale studies has been higher in the TI-RADS compared to other classification schemes. So these are reports that have come out, again, discussing the performance. This is a paper that came out recently that concluded that the ACR TI-RADS offers a meaningful reduction in the number of thyroid nodules recommended for biopsy and significantly improves the accuracy of recommendations for nodule management. This is another paper that came out. This is a receiver operator curve, which basically all we measure. I had to look it up. I don't know medical statistics that great, but you want a large area under the curve, this is just an example of an area under the curve. The bottom is the actual receiver operator curve from this particular paper, comparing it to two other classification schemes. It might be hard to see. The small triangles are the TI-RADS, by comparison, which did in this particular study have the larger receiver operator, or the larger area under the curve, which suggests that it was slightly superior to the other classification schemes in this instance. And just the overall, if you look at enough thyroid ultrasound reports, there's a lot of variability in the way that these things are reported, a lot of variability in the recommendations that are given. Implementing a structured report does two nice things for referrers and clinicians: a better description of features that are predictive of malignancy, and increases the number of reports with definitive management recommendations. So we can be really helpful in those two ways by implementing a system like this. So if you're familiar with mammography, you've heard of BI-RADS. This is not as widely used or required as BI-RADS. It's not as widely used as BI-RADS. Obviously, as I pointed out, there are other classification schemes out there. I think my opinion is that as long as you use one and you're consistent with it, utilization of any of the classification schemes is helpful to your referrers and your clinicians, because they all have a lot in common. Actually, there's more in common with the classification systems than there are differences. So utilization of any of the classification systems can be helpful to your clinicians and increase your consistency and avoid ambiguity in reporting. So some additional resources. There's a 3-part webinar series on the ACR website. A lot of the information in this PowerPoint came from these 3 different talks that were given. In fact, Dr. Tesler is down at UAB. He's been one of the major influences in this TI-RADS system one of its biggest proponents, so kind of a local connection there. If you happen to get an ultrasound report that doesn't include a scoring system on it, there's a nice website that you can go to, and basically it's kind of nice. You just punch in the characteristics of the nodule, and it basically sums it up, gives you a TI-RADS score and the way to manage it. So in conclusion, thyroid nodules are common. Thyroid cancer is not uncommon, but it's not that well understood, and there is recent evidence has suggested the existence of subclinical malignancy, suggesting that patients will die with rather than die from thyroid malignancy. It's important to understand the role and limitations of imaging to avoid unnecessary improper imaging and subsequent FNA or biopsy. The TI-RADS system and lexicon is a relatively new system that offers an accurate and consistent way of evaluating thyroid nodules and assisting in management. And while other classifications do exist, evidence has suggested that TI-RADS is at least as effective and can be superior in many instances for classification and guiding management. So that's all I've got. Any questions I can answer? Yes, sir.
Do they make any recommendations about how to follow nodules in individuals that have these thyroid cancer risk factors, particularly
No.
radiation?
No, that's I looked for something like that, and that's, you know, there's no, I don't have any good advice there. I couldn't find any information that had any specific recommendations on that. Yes, sir.
Is there any geographic area that has a higher instance of thyroid tumors, or any section of the country?
Within the U.S.,
Yes.
Not that I'm aware of. No more questions? All right. Thank you.